Pune, and good evening for people who are not in Pune or who are in another part of the world. Welcome to the Pune International COVID Knowledge Exchange, which is what it is. We're all here to exchange knowledge about COVID for hopefully to help Pune and Punekars breathe better. That's why we call ourselves Operation Breathe. And today, we'd love to have a conversation with you about steroids, when and when not to, and about mucormycosis in COVID. We have a wonderful group of experts who will share their experience and start off the conversation. Um, Dr. Rajiv Soman is a very senior infectious disease specialist and is associated with Jupiter Hospitals in Pune, but he's been associated with many centers there and is very well known. Our own Dr. Priscilla Joshi is a radiologist in Bharati Vidyapeeth. Dr. Prasoon Mishra, ENT surgeon in Bharati Vidyapeeth, and Dr. Baldev Singh from Memorial Hospitals in Florida, in Hollywood, Florida. Just to remind ourselves why we're here to exchange knowledge. Knowledge regarding COVID, knowledge by practitioners, and knowledge by practitioners in the front lines. This is not a theoretical or didactic session. This is exchange of knowledge. We have a brief didactic, but we hope to hear from you. All the discussions are case-based, and please, anyone who wants to bring a case to discuss a case of COVID or COVID complication, please do so. This only works with our motto, we all teach and we all learn. This is directed to involve and somehow assist physicians in the Pune area. We are delighted to have faculty from Bharati Vidyapeeth, delighted to have alumni of AFMC Pune, delighted to have physicians elsewhere who are on the front line of fighting COVID. We're also excited that we have an implementation partner in JPIGO, which is an NGO involved in capacity building in COVID. They're actually working with a number of organizations and administration in Pune. We're very excited that we're connected with Dr. Sancheti and with the IMA in Pune. And we're thankful to Echo India for facilitating all of this. We have a number of representatives from all of these organizations online. So without further ado, I will request Dr. Baldev Singh to set the ball rolling, to talk about steroids and how they use it and what is the literature and what is the practice where he lives. Dr. Baldev, I'm going to stop sharing. So if you want to share anything.
Oh, yes.
Great.
Thank you, sir. Good morning, everybody. We were going to discuss today, as part of a knowledge sharing mission, the use of steroids in COVID, especially in the light of the fact that there's a surge in cases of fungal disease, as has been highlighted in the media in India. My talk is going to be on the steroids as recommended by our CDC and NIH. We may be at variance with what the ICMR is recommending. So, but I'll just present what I have. So that what we are doing in the US. Okay. Can you see this?
Not yet.
No?
Share.
Share it. No? Yes?
Not yet.
Not yet. Okay.
Where's your daughter, Baldev?
I'm on Zoom. Let me see Zoom. Okay, wait. One
Sir,
second. I think I got it.
Bring in the center down.
Yeah, 1 second. Okay, yeah. No. Sorry. Okay. Yeah, it is share. Okay, where's my Zoom gone? Okay. Zoom connect.
It's there, not to worry. It'll be there.
At the bottom, share.
Okay. All right, here. I'll set this one here. Yeah. Can you share now? No?
Sir,
Yes.
have you opened the PPT?
Yeah. Okay.
You
One
opened
Yeah,
it,
select it, hit
Yeah.
the share screen and select
Yeah. I opened the PPT.
and then select the share screen mode on the Zoom, and then select that window of PPT.
PPT I did. Share the on the Zoom.
share screen.
Yes.
It's the green square at the bottom of Zoom.
Yes.
And then
And
you
now?
select the PowerPoint, please.
Oh, okay.
Akash, Dr.
Yes.
Soman is unable to log in for some reason. How can you help him out?
Okay.
All right.
Okay, I'll
A couple
type.
of other people who
Can,
can't log in.
can you see it now?
Yes.
Yes,
Can you see it now?
yes, yes.
Okay. So this was what I took from Dr. Priscilla Joshi. She had put it on a WhatsApp group, and that's the basis of our talk today. Is the use of steroids, because it's suspected that there's an indiscriminate use of steroids in the country. Okay, so I want to share this paper that was published by the recovery trial in the New England Journal earlier this year. Dexamethasone in hospitalized patients with COVID-19.
Josh, can you mute some people, please? There's a lot of background noise. Akash, can you mute all, please? Other than Baldev, please. Thank you.
So this trial was designed to evaluate effect of various potential treatments in hospitalized patients for COVID. And the primary outcome was all-cause mortality within 28 days. The secondary outcome was, for number of ventilator days, for people getting discharged. This was a trial wherein they roped in, they had recruited 11,000 patients, out of which they randomized 6,425. They distributed that in the 2-to-1 ratio, 2,000 getting up the dexamethasone and 4,300 getting usual care. A few of those in the usual care, about 8% also received dexamethasone. Next slide. So this is the demographics of the patient. Their mean age was 66 years, versus 65 years. There were a large number were less than 70 years of age, more males than females, white and non-colored, non-white, I mean. Then there were about 1,535 who received no oxygen. There were 383 who received oxygen, and there were 1,000 patients who were on mechanical ventilation. These are the comorbid features of these patients. So this is the result, the mortality at 28 days. You see that the usual care was worse off than dexamethasone. I can see in panel A, there were approximately 482 deaths in the dexamethasone group compared to 11,000 in the usual care group. That's a rate ratio of 0.83. Even those with invasive mechanical ventilation, they did much better in the dexamethasone group than in the usual care group. I mean, I forgot to say that the dexamethasone was 6 milligram IV for 10 days. In the oxygen-only group, again, the dexamethasone group did better than the usual care group. Rate ratio is 0.82. And those who did not receive oxygen, they fared worse with dexamethasone than with usual care. So this is the chi-square, again showing the invasive mechanical ventilation who were there did fared much better with the dexamethasone. The one with oxygen did fairly well. Those who had no oxygen were getting dexamethasone fared worse.
Thank you. Thank you.
And this is the
You're muted, Baldev. Please unmute
Sorry.
yourself.
Can you hear me now?
Yeah.
Okay. Should I go back to the previous slide or you're good?
No, this slide is good. Yeah.
Okay. The primary outcome, death at 28 days, was less, 22.9% versus 25.7, risk ratio 0.83. Secondary outcomes, those who were discharged from the hospital, again, did much better than those who were on usual care. These are patients who ended up on mechanical ventilators. Less number, 462 versus 1,000 in the usual care group. The number of deaths were also less compared to the usual care group. Then the subsidiary clinical outcomes, the use of ventilation, those who were not on ventilator initially, fewer of them got onto the ventilators as compared to the usual care group. And success, and those who were ventilated, 160 of them were extubated compared to 268 in the usual care group. Again, all these metrics tell us that the patients who were on dexamethasone fared better than those not on dexamethasone. Even those with renal replacement therapy, dialysis or continuous renal replacement therapy, they fewer numbers were on the dexamethasone compared to the usual care group. Conclusion. So use of dexamethasone at 6 milligram for up to 10 days resulted in lower 20-day mortality, 28-day mortality in patients who were receiving the invasive mechanical ventilation. Those who were receiving oxygen also had a lower risk of mechanical ventilation, and those already on mechanical ventilation had a greater chance of successful cessation. There was no benefit and possibility of harm among patients who did not require oxygen. This is as I put in there, first do no harm. Steroids only if patients need supplemental oxygen. Should be continued for up to 10 days or until hospital discharge, whichever comes first. These are in case where there's a shortage of a particular drug, there's a substitute. You can substitute prednisone at 40 milligram, methylprednisolone at 32 milligram, hydrocortisone at 160 milligram. According to the half-life, you can divide it amongst 1 or 2 doses. The shortest acting is hydrocortisone. You can give it in 2 to 4 divided doses. These are some of the adverse effects which we need to monitor, as has been seen recently. They've got, they've got superadded infections. So we obviously need to monitor them, though it's unclear if a 10-day short course would cause these problems. But anybody who's been on long-term, we do have bone marrow transplant patients in our ICU, and therefore we do, take extra caution in looking for superadded infection, especially in case of somebody who's spiked a fever and who has a sudden rise in the white count. So the next study I'm going to present, this came out recently because there's a lot of chatter in our group about inhaled budesonide for early COVID. So this was published, I think, in April in the Lancet. This is also done in Oxfordshire in UK. And this was an open label study, randomized control, where they enrolled 146 patients, 167, 146 were randomized, and they were distributed equally. I mean, they had 69 who got the budesonide and 71 who did not receive that. And the patients who were enrolled were having mild COVID symptoms, meaning thereby they had fever, cough, sore throat, GI symptoms, and they should have had within 7 days of the symptom they were recruited or the test. These are distribution of patients in that group, in that study. Again, age is approximately the same, 44 to 46, slightly more female than male. Again, white, non-white, very few colored. Number of comorbidities almost the same. They had comorbidity of cardiovascular, diabetes. Duration symptoms almost the same. and evidence of COVID-19 positive status. And these were distributed to the symptoms, budesonide unusual care, cough, fever, headache, fatigue, loss of sense, smell, taste. Now, these patients were asked to take budesonide, 400 microgram, 2 puffs twice a day. Those were the ones in the budesonide group, along with the usual care, that is antipyretics and antipyretics, what paracetamol and maybe NSAIDs, aspirin and ibuprofen, along with honey for cough symptom relief. This is the highest temperature recorded with 36, lowest oxygen saturation of 96, so there's certainly not hypoxic. And the cycle threshold was 32.6, 31.8. So this is they were asked to report by the common cold questionnaire as well as the flu pro charts. And clearly at the end of, you can see that the budesonide patients who did better than those who did not receive that. And at day 14, there were only 7 people who were still complaining of symptoms versus 21 in the usual care group. There was one patient who sought care in the budesonide group versus 10 who sought care maybe in the ED or urgent care or were hospitalized at the end of 28 days. So these are violent plots of the temperatures. So clearly the budesonide group had lower temperature, median and mean temperatures compared to the usual care group. And these are the flow pro questionnaires. The first one is overall scores. Then the next one is systemic scores, and then symptom wise, there was a nose, throat, chest, eyes, and GI. In all these, you can see the budesonide patients on budesonide did better than the ones in the usual care group. So the result, self-reported clinically recovery was 1 day quicker than with budesonide, median 7 days versus 8 days. At day 14, self-reported symptoms present in 10% of participants versus 21 of usual care group. Mean proportion of days with fever during the first 14 days was 2% versus in budesonide versus 8% in usual care group. Mean change of the flow pro score of total symptom burden individual domain was
Okay.
That's what I
Yeah, just
the last graph. In conclusion, inhaled glucocorticoid budesonide given for short duration might be an effective treatment of early COVID. The number of participants needed to treat to prevent increased healthcare resource use is 8, and combined with short treatment period required to achieve benefit makes it potentially an affordable and scalable intervention for early COVID. So the idea was to get the patients out of the hospitals and place them on budesonide. And I think that's what the paper said, that they probably were better trying to move them away from the healthcare setting. That's all my.
Thank you, Dr. Baldev Singh. Please keep posting your questions on the chat. Folks will keep responding to your questions. Also, we'll move on, and I'll request Dr. Rajiv Soman, who's a doyen of infectious disease expertise in Pune and in the whole region. And Dr. Soman will share his experience. Dr. Soman, please. Good morning, Dr. Soman.
Yeah, unmute. Okay, good morning, everyone. And it's indeed a great pleasure to be here on this platform. And I'll start my screen share and see if you can get it across. Is it visible, please?
Yes, thank you.
Yeah. Okay, so I'm going to talk about this burning problem, post-COVID-19 mucormycosis, and I have chosen to title it as Realities, Uncertainties, and Myths. So what are the realities about this? I must remind all of us that this is an organism which plays a very essential part in nature. It is ubiquitous in nature, it has the task of recycling organic matter, and inhalation of spores is a daily occurrence. And yet the low virulence of this organism really, because it is a rarity, the disease itself is a rarity which really attests to the low virulence in normal hosts, but obviously it becomes dangerous and aggressive in the immunocompromised. And yes, it really spreads to vital organs even before it is suspected, and these are the mortality figures which have been published. It's an emerging pathogen with a rising incidence, still not very well understood by the general medical community. And let me tell you that it's not the ENT, ophthalmic, infectious disease physician who's going to see it first. It is first going to the family physicians. Unless the physician has seen a critical number of such cases, it's very difficult for him to spot the diagnosis. A word about the pathogenesis. Here we really have to take the bitter with the sweet. And by that I mean hyperglycemia, free iron, and diabetic ketoacidosis and other acidosis too. All this produces a heat shock called as the GRP78, which is expressed on the surface epitheliums as well as on the endothelium of especially the sinus and pulmonary capillaries. And interestingly, mucorales have a particular ligand which is called as COTH3, which is universal in the mucorales, and it is completely absent from all other life forms. So here you have a problem that this epithelium, endothelium is overexpressing this particular receptor for which there is a ligand with the mucorales, and that is the one which allows it to transgress the epithelium as well as the endothelium, produce thrombosis, as you can see in this cartoon. We wrote an editorial way back, let me put it way back in January 2021, and we called it as From the Frying Pan into the Fire. And the reason is India is both the diabetes and mucor capital of the world, and treatment of COVID-19 itself and its treatment amounts to a recipe for disaster. And the reasons are not far to find. It's the dysregulated immune response, innate immune response especially, along with the hyperglycemia, excess free iron, and also the high spore count in our country. That is also possibly important. And all this creates the perfect setting. The recovery trial actually gave a license to use steroids, but people often miss the fine print in that trial, and they continue to use large doses for much longer periods. And that really gave a license, so to say, or to use these steroids. And the Indian physicians often have a cavalier attitude to the use of steroids, which is really an unfortunate reality. What are the other realities? Facial pain, numbness are the early symptoms, and the hallmark of this disease is tissue necrosis. And so what the clinician is actually looking for is a necrotic lesion, a scar, black discharge. And then we have these kind of involvements, which are all ominous signs, must be taken seriously. Often without most physicians, at least in the still the recent past, were making alternative erroneous diagnosis, and that would lead to further antibacterials and worse to further steroids, which would obviously add fuel to the fire. I put in an audience question here. Which of the following biomarkers is useful in the diagnosis of mucormycosis? Is it the beta-glucan? Is it galactomannan? Or is it mannan, anti-mannan antibodies? Or none of the above? Should I pause here for some response? Or
Yeah. Please type your question, answer in the chat box. Okay. We have one answer, D, A.
So I'm with you if your selection is none of the above, because that's the important thing here to remember, that there is no biomarker for mucormycosis. And therefore, the mainstay of diagnosis is biopsy. Okay, so that is the important point here. And in fact, sometimes finding negative biomarkers, beta-glucan is there in many fungi, including Candida. Galactomannan is again present in some of the molds, but most notably in aspergillosis. Under the relevant clinical circumstance, if you have negative biomarkers, in fact, you must consider that as a pointer towards mucormycosis. The fact remains that biopsy is the mainstay, and the benefits outweigh the risk because otherwise you cannot proceed at all unless you make a firm diagnosis. So despite other problems like location of the lesion and coagulopathy, I would strongly urge a biopsy to be made. Even then there are problems such as a sampling error could be there. There needs to be a good communication with the lab because they need to process that sample in a particular way. And most importantly, differentiate it from other molds with morphological characteristics and so on. Even more important is to document tissue invasion and a reaction. Now here is a picture which I don't know whether my pointer is working, but the first one shows you the optic nerve fibers which are stacked vertically, and there is the mucor which you can see over there, which is actually adjacent to those fibers. And here is a cross section of a vessel, and as you can see, the fungal hyphae are both inside the lumen as well as in the wall of the vessel. So this is a final proof that this is an invasive fungus. So tissue and vascular invasion are important things. You should also be doing a culture and identity of the genus, species, and perhaps even MICs in order to further refine your diagnosis. So in the realities, what are the pillars of treatment? It is the antifungal therapy, it is debridement, it is adjunctive therapy, it's reversal of the underlying cause, and needless to say, we need a multidisciplinary approach. So I come to the next audience question, and that is, while liposomal amphotericin B is the mainstay of treatment, what from the following is true? Posaconazole is approved as first-line treatment. Isavuconazole is approved as first-line treatment. Voriconazole is a useful alternative, and all of the above are true. Again, I'm looking at the chat box. Do we have any responses?
Yes.
Majority of saying D, all of the above.
Oh, that's never, when I make MCQs, it's not always the right answer. Okay, so important thing here is posaconazole is not yet approved as the first line treatment. Remember, most Western studies have focused or used this drug as a prophylaxis in hematologic malignancy population. So most approvals for posaconazole are still for prophylaxis and not yet for treatment, but I'll come to that a little later. Isavuconazole is indeed approved as first-line treatment, but the most important reason why you should not select all of the above is voriconazole is in fact not only not effective, but it is positively detrimental. Voriconazole has certain characteristics which will increase the pathogenicity and angioinvasiveness of this fungus. So again, my point that we need to distinguish mucor from bacterial infections, mucor from aspergillosis, because treatment is completely different. And there are, like the voriconazole is the drug of choice for aspergillosis, but it can be detrimental for mucor. So because C is such a wrong answer, obviously all the other things, all of the above is not true. One World guideline was put together by the European Confederation, and I'm a part of that guideline. So I would strongly urge all of you to look at this. It's a initiative of ECMM and a mycosis study group. And again, this is a busy slide and I'm not going to labor this, but what is important is certain points emerge here. The dose response curve for mucormycosis is very steep, and therefore we need large doses, and the doses need to be started right in the beginning. There's no sense in trying to escalate the dose. Okay, so liposomal amphotericin B is the drug of choice, mainstay of treatment, but there is an alternative such as isavuconazole. And then as we go here, it becomes orange and red. And so if the patient has been given this, we reassess that patient and then look at whether there is stable or partial response or progressive disease or toxicity, and then make suitable changes in the form of switching over to isavuconazole or posaconazole and so on. So it's a little busy slide, but I would certainly urge you to have a look at it. Also, the physician needs to be reminded that treatment has not begun until adequate debridement has been done. And what is the reason for that? There is poor penetration. We discussed that there is vascular thrombosis, and therefore the drug that we give is not going to reach the site of infection. Also, it's important to know that even non-viable hyphae may precipitate thrombosis, and they produce this terrible toxin called as which is recently named as mucormycosis, right, in January this year. And this produces a lot of inflammation, vascular permeability, hemorrhage, and what have you. And this is the kind of debridement which is required for many patients. So you need to remove the wings of sphenoid, you need to remove the maxilla and everything here. This is a lobectomy specimen of the lung, which shows a large mucor lesion here, and this is at temporal abscess of the brain resection. Okay, so all these organs need to be tackled. There are no sort of no-go areas in the body. You need to do that, and you need to do it repeatedly. The limits of excision are sometimes defined by frozen section or calcofloor. And although I say debridement is pivotal, there is something called as a survivor selection bias, where the patients who are perceived to be at a highest risk of adverse outcome, but are acceptable surgical risks, are offered surgery. And therefore, there could be a little bit of a bias there. So you need to put in obturators, which could be later repaired by a means of a muscle graft. Sometimes you can land up with a CSF rhinorrhea, which needs to be patched. So the sky is the limit. You know, any amount of debridement, any amount of reconstructive surgery is required. And certainly we need a multidisciplinary approach for this. So if you have a gastrointestinal hemorrhage, you need services of your GI friend who will do an endoscopy and find this black colored lesion in the stomach, which turned out to be mucor. This post-COVID patient had this large lesion and massive hemoptysis. There was no way to make the diagnosis of mucor. Only a lobectomy could have worked as a diagnostic and therapeutic procedure. CT angio was done, which shows this large mycotic aneurysm, which was appropriately coiled. So in short, every possible department of the hospital is needed for the treatment of this. The next point I talked about was isavuconazole has received approval as primary treatment on the basis of this trial. One of them is called the VITAL trial, and the other one is SECURE trial. In addition, this is a small study, but it's an analysis of the fungiscope data, and it's very interestingly called as MOVE ON. And in this, what they found is posaconazole new formulations were effective in terms of treatment response and the associated mortality in mucor, and it may be an alternative for treatment of mucormycosis, although the limited size of this study calls for a cautious interpretation. So the uncertainties are antifungal therapy. Should it be single agent? Should it be combo? Most authorities would favor a single agent, but which agent to be selected? What's the bioavailability of some of these oral agents when they are being given as crushed tablets or open capsules through a feeding tube, and reminding you that feeding tubes are necessary in these patients because of the debridement which is often carried out. At what stage will you transition from the amphotericin B to something else? What will be the total duration of treatment? And what can be offered in salvage treatment? These are all important questions. I can't go into all these details because, but if there are any questions, I would like to address them. Again, the debridement, when? As soon as possible. How much? Okay, so that depends on many factors and certainly repeated if required. Now, adjunctive therapy, I listed for you some of these, but remember that all of these may have adverse effects, costs, may not be available on site, and there is a little bit of an uncertainty in their efficacy. Reversal of the underlying cause also poses challenges in some. It's very comparatively simple to reverse neutropenia. It's comparatively simple to treat hyperglycemia. But when you don't even know what is wrong with the patient, what are you going to reverse? Like what is the immune dysregulation which has occurred in COVID-19? We don't have a great clue about that. We certainly can't reverse it easily. And in COVID-19, are there differences in the disease manifestation? I personally think that the maxilla is bearing the brunt of the disease, and there are a few characteristics which seem to be different. Are we able to control with our same usual arsenal, or is it becoming really uncontrollable? Is there the same genus species? Is there some resistance which is developing? These are all uncertainties. Also, I remind you that not everything post-COVID-19 is mucormycosis. For example, all these are patients of COVID-19 who were treated with steroids. And this is a patient who's clearly got herpes simplex, very bad infection in the mouth and on the vermilion border and so on. And this is a patient who actually underwent a nasal fess with the suspected diagnosis of mucor, but this was clearly headache, swelling in the eye and redness here, and it was a varicella zoster. Now, this is a patient who had nasopharyngeal and pharyngeal involvement post-COVID-19, post-steroids, and it actually turned out to be histoplasmosis. In this patient, there appears to be a nasal turbinate eschar, and certainly this could be mucormycosis, but probably as a result of the steroids, the patient activated tuberculomas in the brain. So this is obviously tuberculomas and not that particular mucor. Are there any myths? Yes, we are just sort of swept over with myths. It's really not a black box. Certainly the organism might, the disease might make parts of the patient black, but the fungus itself is not black. There is no human to human transmission. I told you that these spores are inhaled on a daily basis. So there is no question of that. Infection control issue in the hospital and community to some extent, yes, because hospital air, which is also drawn from, we don't live in rooms with HEPA filters and all these things all the time. And therefore, there is a problem. But use of gloves, gowns, masks is not really required just for the sake of mucormycosis. What about prophylactic mucor agents in these patients? If you really see the incidence, and we did look at some of our institutions and what was the actual incidence in a patient with a longitudinal follow-up, and we found that it is not really too much. We do see a very huge number of patients, but there's a referral bias to infectious disease physicians and so on, and therefore we really don't know the denominator because they are coming from other towns and states and so many other places. What about a vaccine? Everyone fondly hopes for that, but right now we don't have any vaccine for mucormycosis. But if you remember that COT-H3 that I talked about, experimentally they have raised monoclonal antibodies against that particular fungal ligand, and that has protected mice. So maybe sometime vaccine may turn into a reality. I'll close by a few thoughts. Our understanding of mucormycosis is extrapolated from the pre-COVID-19. Diagnosis and staging is of absolutely pivotal importance. Management may actually range from an organ sparing strategy, low dose single agent therapy, to mutilating surgery, high dose combination therapy. And at times, all this is driven by desperation, availability, scarcity of drugs, toxicity, and cost. The underlying cause, which needs to be handled, is of course tangible and reversible in most patients, but it can certainly be elusive and irremediable in some of the patients. So when we see 100 cases of mucormycosis, we think, okay, I've seen them all, but it's not like that. Every patient is different, and we need for an optimal management, a very nuanced, tailor-made approach. And with this, I'll stop here, my screen share, and if there are any questions, we'd really be happy to take them.
Thank you. Thank you, Dr. Soman. There's already a lot of questions for you. But and it's a succinct and wonderful presentation. So in order to keep moving the conversation on, I will request Dr. Joshi to present the radiological features next. Dr. Joshi, please. Priscilla ji. And please post your questions because we'll try to post it in real time. The experts will, while the conversation is going on. So we'll have more time.
So greetings to everybody. I'm Dr. Priscilla Joshi. I'm a radiologist at Bharati Vidyapeeth, Pune. And it's a tough act to follow Dr. Rajiv Soman, but I'll try to show you some images. I'll basically show you PNS, paranasal sinus involvement and extension into various adjoining structures. So fungal rhinosinusitis can be either an allergic fungal rhinosinusitis, invasive fungal rhinosinusitis, or non-invasive aspergillomas, which are chronic. So we are going to look at this in the next few minutes. So rhinocerebral mucormycosis, early imaging is helpful in assessing the extent of the involvement of this lethal disease, which requires prompt and aggressive treatment, like Dr. Soman just told you. Which is the right imaging modality? Definitely not an X-ray of the paranasal sinuses. We'll look at the pros and cons of CT scan and MRI. CT is quick and especially useful in a restless patient. Bone destruction is better appreciated on CT. The soft tissue in the paranasal sinuses can be evaluated. Fat stranding in the orbits is well seen. Contrast is required to evaluate for meningeal involvement, cerebritis, abscess formation, cavernous sinus involvement. MR Of course, has better soft tissue resolution. Evaluation of soft tissue is much better. Marrow edema is well seen, like I'll show you in slides as we go by. Skull-base osteomyelitis is well seen. Intracranial and intraorbital extension, cerebral edema, infarcts, cerebritis, cavernous sinus involvement. We can do an MR angiography post-contrast to look at the vessels. Cranial nerve involvement is something which we will not see on CT, and MR has an edge over here. In all cases, contrast scans should be done, and one should have a look at the renal function, because if renal function is impaired, you may not be able to give contrast, and diabetic patients sometimes have associated CRF. So before we go on to the abnormal, let's have a look at the normal anatomy of the paranasal sinuses. That's the nasal bone there, the nasal septum, nasal cavities, the frontal sinuses here. We are all familiar with this, but it's just a recap. I want you to appreciate that this thin bone between the nasal cavity and the orbits on either side is the lamina papyracea. It's a thin, paper-thin bone, and it can be easily invaded. These are the maxillary sinuses on either side. Again, you have the crista gala, you have the cribriform fossa over here. So this is another site for invasion, intracranial invasion. That's why I'm showing you this, the maxillary sinuses, the nasal turbinates, which again can get destroyed in mucor infection. That's the nasal septum you're seeing there, the ethmoidal air cells. The sphenoid sinus, another important area, because you have important structures here. You have the optic canals with the optic nerves. You have the cavernous sinus, which is there on either side with the internal carotid arteries, the third, fourth, sixth nerves, and the V1 and V2 branches of the fifth nerve. So this is a very, very important area which we look at when we are imaging these patients. That is the pituitary gland in the center, the pituitary stalk, and the cavernous sinus on either side. An axial image, again showing you the ethmoidal air cells, anterior and posterior ethmoidal air cells, and the sphenoid sinus. So all these areas are what we evaluate when we are looking at the CTs or the MRs. These are the pterygoid plates and the pterygopalatine fossa. That's the Vidian nerve canal, and that's the foramen rotundum. MR images showing you the same thing, and you can see the soft tissue is much better seen. You can see the optic nerves. You can see the orbital fat should be, this is a T2 weighted image, so the fat should be bright and clean on this. And these are the orbital muscles, the superior inferior rectus, medial and lateral rectus. That's the ocular globe over there. As we go backwards, we can see the optic nerves, the muscles going towards the orbital apex. And then we go on to the brain. The sinuses contain air. That's why they are black on MRI. Anything containing air is black on MRI. So the maxillary, the ethmoid, all the sinuses will be black. So it's easy to pick up if there is some abnormality within there. So on CT, what do we see in a case of mucormycosis? There is near complete opacification of most sinuses. The plain CT sinus, on plain CT, the sinuses are opacified by central, often serpiginous, hyperdense material with a peripheral rim of hypodense mucosa. In 40% of patients, there can be an expansion of the involved sinus, remodeling and thinning of the bony sinus wall, and erosion of the sinus wall. So let's look at examples of these. There's extensive destruction of bone, demineralization of bone. You can see the soft tissue in the right maxillary sinus. The medial wall is eroded to some extent. The skull base is showing extensive involvement. If you look at the soft tissue, you can see extensive soft tissue here, and the soft tissue is showing increased density, which we called as hyperdensity, which suggests fungal infection. This is an area we also look at. These are the ethmoidal air cells. This is the lamina papyracea, and you can see that there's thinning of the lamina papyracea and there's intraorbital extension on the left side. The normal fat within the orbit this is what it should look like, and this fat has been invaded and you're seeing soft tissue there, which is abnormal, so there is intraorbital extension. On MR, what do we see? On T1 weighted images, we see a hypointensity, and on T2 also a hypointensity can be seen. I'll just show you the examples. On T1, the inflamed mucosa is hypointense, and it may sometimes be hyperintense as well. Whereas on T2, there is a central low T2 signal intensity due to the high concentration of metals such as iron, magnesium, and manganese, which are concentrated by the fungal organism. So this is pathognomonic of fungal infection if we see a hypointensity surrounded by bright tissue on the T2 weighted image. And on post-contrast images, there is no enhancement in the central hypointensity, whereas the inflamed mucosal lining will enhance. This is in contrast to a malignancy where the entire thing would enhance. So let's see some examples. This is a patient, of course, who was not COVID. We had seen this patient maybe about 4 or 5 months ago, and not 4 or 5 months ago, but a year ago. And this is the bright mucosal thickening, which is seen. The central part of it is hypo intense or dark because of the presence of iron, manganese, or magnesium. And this part does not enhance. These are post-contrast images, and the central part enhances, whereas the peripheral part, the mucosal inflammation, enhances. So we go through an imaging checklist when we are evaluating patients for sinus and orbital as well as cerebral involvement. So the first structure we of course evaluate is the paranasal sinuses. We look at the walls of the sinuses, we look at the trabeculae of the ethmoidal air cells, the nasal turbinates, the nasal septum, the lamina papyracea, look for intraorbital extension, maxillary palatal involvement, cavernous sinus, pterygopalatine fossa, and masticator space involvement. This disease extends everywhere, so we have to look on all sides. The floor of the anterior cranial fossa, the cribriform fossa. We look at the brain for cerebritis, meningitis, abscess formation, infarcts, and at the vessels and nerves as well. So let's look at a few examples. This was a 61-year-old lady who presented with left orbital cellulitis. She had debridement done 3 days prior to the CT. You can see there's extensive demineralization of the bone over here in the ethmoidal, surrounding the ethmoidal sinuses. The medial wall of the left orbit, that's the lamina papyracea, again is thinned out. There appears to be intraorbital extension. The inferior rectus muscle here is bulky. And there appears to be extension and involvement probably towards the brain as well. You can see a dehiscence in the roof of the sphenoid sinus here, soft tissue in the sphenoid sinus with some density within it. These are bone window images. PNS, always we look at both bone window and at soft tissue windows, especially in a setting of mucormycosis, but otherwise as well. Her axial images showed thinning again of the lamina papyracea with soft tissue in the ethmoidal sinuses. And this was her video of the soft tissue window, which is showing you that there is extensive involvement of the left orbit. You can see that there is the left inferior rectus is bulky. There is a peripheral enhancement there suggesting an abscess formation, extensive stranding. The optic nerve also is showing some enhancement. You can see this abscess over here. These are post-contrast images. And if you look at the left side of the face and the right side, you can see that the soft tissue here is much more. It's showing abnormal enhancement, and there is a lot of fat stranding over here overlying it. The sphenoid sinuses are also involved. The cavernous sinus seems normal. There is no cavernous sinus, or cavernous sinus thrombosis is not seen in this patient. The next patient, which I'm going to show you, is a 46-year-old post-COVID, swelling and pain over the face for 7 days with diminished vision since 2 days. These are MR images which are showing you the orbit. Normally, these are fat suppressed images. So the fat within the orbit is suppressed and is dark. So any edema within the fat will appear bright, as it is on this side. You can see normal signal within the orbits on both sides. The inferior rectus here again is bulky. There is intracranial extension. The right frontal lobe is showing an abnormal signal over here, also seen in the other images. And this is showing some central hypointensity, suggesting again fungal infection. You can see the hypointensity within the soft tissue. By hypointensity, I mean this dark area within the surrounding bright soft tissue within the ethmoidal sinuses as well. MR helps you in picking up marrow edema much better than CT. You can see the bone will appear dark or black. This is a stir image, which is a fat suppressed image. So the fat within the marrow is suppressed. So any edema shows up well. So if you compare this side, which is normal, to this side, which is abnormal, you're seeing the bright signal within it, suggesting the edema. And of course, the sinus walls are appearing abnormal, and there is the soft tissue within the sinuses. The same patient, if you look at the ocular globe on the left side, it is compressed because of involvement and inflammatory soft tissue over there. The frontal sinuses are affected. The frontal lobe, you have this lesion, which is showing restricted diffusion. This is because of the angio invasion. And you have infarcts here in the right frontal lobe as well as in the left occipital lobe. This was an angiography of the same patient. And you can see the extensive premaxillary soft tissue edema in this patient, edema in the infratemporal fossa on the left side in the pterygoid muscles. You can compare it with the right side, which is relatively normal and not showing you the edema. So extensive disease, and you can pick up the extension well on both CT and MR. The CT, of course, shows you the bone dehiscence much better. And you can see extensive involvement. You can, the left, if you look at the maxilla, you can see on the left over here, you're seeing air within the maxilla, indicating that there's erosion over there and involvement of the maxillary alveolus over here. Just a quick run through of the video of the same patient showing you the maxillary findings, which I told you there is air here. You compare it to the opposite side, the soft tissue involvement of the cribriform fossa, which caused the intracranial involvement. See the deossification of the trabeculae on both sides, soft tissue in the sinuses. Of course, you see the soft tissue swelling on this side as compared to the contralateral side. This was a 37-year-old patient post-COVID who was a case of angio-invasive mucor, operated. The patient had cavernous sinus involvement, as you can see on these images. If you look at the image on the right, sorry. If you look at this image, you can see there is opacification of the cavernous sinus on post-contrast images, whereas this on the right is showing you a filling defect. There is involvement of the right internal carotid artery, and that's why that has resulted in an infarct, which you're seeing on these FLAIR images showing restricted diffusion. The patient had been operated before that, and debridement had been done. This was a 78-year-old male patient, 20 days post-COVID, known case of diabetes, who had received steroids, and you can see that the optic nerves are showing abnormal signal on either side. There's abnormal enhancement seen along the optic nerve sheath. And the patient also had involvement of the nerves, which was well seen on these images. You can see the V2 branch of the trigeminal nerve is showing you abnormal enhancement. The patient also has this collection here. This is on T2 weighted image. This is post-contrast T1 showing peripheral enhancement. This is in the region of the Meckel's cave. You can see the cavernous sinuses here also showing abnormal enhancement on both sides. Of course, the soft tissue in the sinuses is there as expected. I had shown these images last time, but just to go over it again, you can pick up cavernous sinus thrombosis even on CT scan, as we saw in this patient. This patient, unfortunately, is no more. He also had infratemporal fossa abscesses, temporal lobe abscesses, and abscesses in the masseter muscle. So this is another patient who had temporal lobe abscesses, known case of right maxillary sinusitis, which was angioinvasive. This is extensive involvement of the lateral and posterior walls of the maxillary antrum on the right side, and involvement of the temporal lobe as well. Periantral fat stranding, and the black turbinate sign, which has been talked of so much over the last few days. Of course, this is showing you the classical hypointensity within the soft tissue, within the sinuses in these patients. So what is this black turbinate sign due to? As we all know, it's an angioinvasive fungal infection. So the infarcted tissue is non-enhancing on contrast images, and the surrounding tissue is enhancing. The contralateral turbinate also will enhance. So that's what produces this black turbinate sign. So it is supposed to be an important sign for the early detection of invasive fungal rhinosinusitis. There is a staging system also for involvement, for radiological involvement of the sinuses, and stage 1 is the nose and paranasal sinuses alone. Stage 2, paranasal sinuses with immediate adjacent areas which are surgically resectable with minimal morbidity, like the orbit, palate, and oral cavity. And stage 3 talks about intracranial extension with or partially resectable extension to the pterygopalatine fossa, cavernous sinus, cheek, and periorbital region. So the take home here is imaging is essential to evaluate the extent of involvement, especially orbital and intracranial involvement. MR is the imaging modality of choice. Contrast is essential for optimal evaluation. Renal function should be normal for it. In the appropriate clinical setting, subtle extrasinus extension in the form of fat stranding in the premaxillary, retromaxillary fat, orbital fat stranding, and altered fat in pterygopalatine fossa are important to suggest the diagnosis of invasive fungal infection on imaging. Thank you.
Thank you, Dr. Joshi. We'll move on to Dr. Mishra. Also, I see that there's an active conversation going on the chat. Request all the speakers to please keep answering the questions so we have more time for more discussions as well. Dr. Mishra, please.
Yes, sir. Thank you so much, previous speakers. After your talk, my job has become extremely easy. I promise to keep my talk very short so that we have more time for discussion. I'll just share my screen. Is it visible?
Not yet. We're waiting. Just open your PowerPoint, go to share screen.
Yeah, it's already open. Already open.
Yeah, share screen, and then you'll see your PowerPoint, and then you select that.
Yeah, got it. Yeah, is it visible now?
Yes.
Yes.
Yeah, so I'm Dr. Prasanna Mishra in Department of ENT, Bharati Vidyapeeth College, and various hospitals in Pune. As Dr. Soman, Dr. Baldev, and Prashila Madam has already described the basic features, the investigative modality, my job has become extremely easy. I will not be going into details of every aspect of this. Definitely, this becomes a multidisciplinary approach, including infectious disease, physicians, ENT surgeons, radiologists, oculoplastic surgeons, reconstructive surgeons, and not to forget the microbiologist and the pathologist. So each one in this team is extremely important when we are treating a case of mucormycosis. If any specialist feels that he is the sole person treating, I am sure he is wrong. And why the symptoms develop, as Dr. Soman told, that these fungus proliferate in the tissue, in the vessel wall, perineural spaces. They have a high affinity for the muscle layers of the vessels. And when they reach there, this leads to thrombosis and infarction. And that is why all these symptoms that have been mentioned earlier, that nasal turbinates, bone, orbit, the cranial vault, even intracranial extension and cavernous sinus, they get involved. So mainly it is the thrombosis and the infarction which this fungus is causing. So I would suggest, yes, ENT surgeons should be the first one, but most of these people will be visiting general practitioners, physicians. So whenever you keep a high index of suspicion, it is good to refer the patient first to ENT OPD, because at ENT OPD, we are clued up to take a proper history for mucormycosis. We will be doing a clinical evaluation of the nose with an endoscope. We will be seeing the eyes of the patient, evaluating it, the face of the patient, the oral cavity, which includes the alveolus, the teeth, the palate. After evaluating, we will put an endoscope, a 0 degree, a 70 degree, and see inside the nose. And definitely, I believe endoscopy would be one of the earliest modality of evaluating the patient, because that will give us any initial changes that is happening in the mucosa. And if there is some tissue, we can even take a small biopsy in the OPD itself, so we can get a quick diagnosis. The common presentation, how this patient present is, when we do a nasal endoscopy, normally for non-ENT people, when we put an endoscope inside the nose, we should be seeing the elevations, depressions, that is turbinates, mucosa, all should be pinkish. The moment we see any change in the mucosa, it initially starts with a pale looking appearance. And as the ischemia and the necrosis progresses, this pale looking area starts becoming black. So the moment you see any, like this is in the middle turbinate, this is the blackening of the inferior turbinate. We are even seeing some more blackening. So the initial sign would be a pale looking appearance of the mucosa, followed by blackening or eschar development. In the palate, mind you, these are all my patients we have been treating in last a month or so. These initially the palate, it may normally when we see a palate, again it should be a pink looking palate. However, a chronic tobacco chewer might have a pale looking palate area, but it will be a continuous and a throughout pale area. If when we see the palate of a person, the oral cavity, if it is at a localized point, we see any pale, even minimal, have a high index of suspicion. Initially, it will be pale. As the necrosis increases, it leads to development of black color eschar on the palate. And gradually, if you very carefully see, there is also, it starts development of fistula. So it is increasing, it is the ischemia and the necrosis, which is gradually ischemic, and it is gradually increasing from pale to blackening, and which continues as a eschar or a fistula. In the orbit, initially, in this present scenario, the most common kind of presentations that we have seen is patients coming up with these kind of proptosis. The moment we open the eyes, they have very good vision. So a patient with generalized with a proptosis of one side, again have an index of suspicion that this can be a case of patient going into mucor. This patient is already intubated, but if you carefully see that this proptosis is coming up on the right side. A gradual stage-wise, what happens is chemosis develops, that is reddening or the congestion happens of the conjunctiva. The movement of the eyeball gets restricted, and then gradually as the optic nerve involvement sets in, patient goes into vision loss. In the face, again, if the general physician or physician has a high index of suspicion, especially in a post-COVID patient with a high sugar level, highly deranged HB1AC, if you see this person, there is definitely a periorbital swelling. Even in this female, the husband was very attentive. He saw this, that I think my wife is developing swelling on the left side, and very carefully if you see that there is a left side swelling, and when we did the endoscopy, the middle turbinate was completely black. As Dr. Soman very rightly pointed, this time we are seeing that the turbinates and the maxilla along with the palate are seeing the initial or the major part of the brunt. Definitely eyes are also getting involved. During debridement, what we do is, as ENT surgeons, we are very clued up to all this area, and endoscopically, we open all the sinuses, the entire medial wall of maxilla, even the medial wall of orbit can be decompressed. We can give external incision, partial, total maxilla can be removed. Once the maxilla is out, even a part of infratemporal fossa or the pterygopalatine area can be cleared. And definitely, if the eyes or the vision is lost, we try to preserve the globe as far as possible. But once the vision is lost, there is no option but to go for a lid preserving orbital exentration. So these are some photographs where we do endoscopically, we remove all the tissues from the sinuses. The idea is, once we are removing, normally mucor does not bleed. We keep debriding till we see good, nice pink bleeding mucosa. It means that that area is getting good blood supply, and it is not that all the mucor has been picked out and removed. It is that this area is getting good blood supply. So the amphotericin with the physician and the infectious disease specialist will start. That is going to reach that area, and patient will have a very high chance of recovery. We even do maxillectomy. If you see the first photograph, this patient, Dr. Prashila Madam definitely showed the CT scan. She just had a palatal erosion, and we had done a nasal debridement. But when we did, when Madam told that the maxilla is involved, we went ahead. Patient agreed for a maxillectomy. If you see carefully, the medial part of the maxilla, as we retract the skin, has become complete, and this patient will present the removal. But he had got cavernous sinus involvement. In this series of mucormycosis, Dr. Soman will agree that we are seeing more of subcutaneous or the skin involvement in the face and the forehead area also. And this child, we did a orbital exenteration, maxillectomy. We tried to remove the skin. We can see a good pinkish area, but because of the intracranial spread and the deranged electrolytes, we could not save this child. This is the patient after maxillectomy. So we need to understand, as physicians and practitioners, sometimes we have, or even the patients have this idea that once the maxilla is removed, my face will become deformed. No, it does not happen. The shape of the face comes because of the zygomatic prominence and not because of maxilla. So in spite of this lady having maxilla removed, we have sutured it nicely. And after a month, this scar is hardly seen. Orbital exenteration, again, a very important but a definite decision which needs to be done. It is a very, to see a patient with orbital exenteration, we have an idea that it will be something like an eye open area. It will a ghastly kind of look will be there. But understand, once we suture the eyelid, the appearance is not that bad. And once the patient improves, definitely a prosthesis can be put there and vision may not come, but the clinical appearance can be made to near normal. This is a lady who has done very well after orbital exenteration, 6 weeks of a good proper antifungal treatment under guidance of infectious disease specialist. And now she's in a stage where we can call him cured. We don't see any of the fungus in her sinuses. And we are now referring him to a prosthodontist for a good prosthesis. And I'm sure she will have a good clinical appearance after that. Last one, 2 slides, that is we need to have a good patient counseling at all the levels, general practitioner level, physician level, whatever level we are interacting one-to-one with patients, that this disease is a disease with extremely high mortality. Patient needs to take a long-term medical treatment. Debridement is definitely an aggressive procedure, but we need to counsel the patient that this debridement is extremely essential to save the life. And once the life is saved, patient survives nicely for 1 month, 2 months, all the debrided part can be very well reconstructed. Whether it be a maxilla, whether it be a orbit, most of the clinical appearance will definitely come back. So reconstruction is not a problem. The initial point is that we should be aggressive in debridement, and as has been told, a high dose of liposomal amphotericin should be given along with this. So take-home message, which I would like to say, is always have a high index of suspicion in patients who are post-COVID with a deranged blood sugar level. Whenever in doubt, refer to ENT surgeons, because we can do a nasal endoscopy and we can try to detect this case earlier. And treatment is repeated debridement along with suitable antifungals. I end my slides. Thank you so much, and we are open to all questions.
Thank you. Thank you. In the interest of time, I'm going to try to rapidly combine some of the questions. Dr. Padmanabh Keskar has asked, why are we seeing so much more mucor in the second wave? And also I want to ask if liposomal ampho is not available, should we use conventional lyophilized? Dr. Soman, perhaps?
You already texted the answers to both these questions, but if you want, I'll sort of reiterate them. In the first wave also, there were a lot of cases, mainly they were in Gujarat and Rajasthan, also a smaller number in other parts of the state. However, in the second wave, so to say, there are a large number of cases in Maharashtra, Tamil Nadu, and Karnataka, and so on. And even now, the eastern states have far lesser number. So obviously, weather, climate, score count, and other prescribing practices, obesity, diabetes prevalence, all these probably are factors. But there's no data on by which I can. This is all speculative. The other question was about the deoxycholate. So, if you look at guidelines issued by various societies, they sort of proscribe. That means they do not want you to be using amphotericin B deoxycholate. And there are many reasons, apart from the obvious reason of nephrotoxicity. For those who are interested, let me tell you that the liposomal amphotericin B goes much beyond just the nephrotoxicity part of it. The liposome delivers the drug very close, or actually to the fungus. Okay, so it is like a directed therapy. Comparatively, it doesn't get delivered to the kidney and some of the other organs to that extent. So there is something there. Also, the liposome also exerts certain immunomodulatory properties, which also may be beneficial in this disease. And finally, you can go up to 5 or even 10 milligrams at times per kilo, whereas the ceiling dose for deoxycholate is only 1 milligram per kilogram. Okay, so you can actually realize the full potential of this drug because you have made it, packaged it in the liposomes, and thereby enhancing delivery to the site, reducing delivery to the area where there is toxicity, and also these immunomodulating properties. I can give a big lecture on that, but I think I'll stop here. Is there any other question for me?
Yes, I think this has probably been covered, but it's important. Dr. Gujarati asked, well, a lot of this is going to be seen in inpatients. What can a primary care doctor do?
No. I have always been advising whoever listened to me that when a patient is discharged, it should be mentioned on the discharge paper that these are some of the warning features. Now, you may not use the word mucormycosis, but in case you have facial pain, numbness, swelling of the nose, eye, stuffiness, headache, or black colored, red colored nasal discharge, do not take it lightly, but see a physician who's tuned to, and perhaps also don't take antibiotics, don't take more steroids, but have a proper medical attention. So many of these cases are discharged and they get this outside. So it's not that almost everybody gets it while in the hospital. Certainly there are patients who do get it because they are stuck in the hospital for a long time. Somebody had also asked what is the time frame in which happens, and I have seen some cases which would occur even within as short as 1 week, but on a median or average, I would say roughly about a month later. So obviously, patients would be at home at that time and might present in these particular ways.
Dr. Soman, what about patients who are on steroids and you have to prolong their course? What do you do then?
Yes.
Beyond 10 days? Do you ever have to do steroids beyond 10 days?
Yeah, so sometimes, for some reasons which the pulmonologist knows, and we generally have a sort of a discussion like how important do you think the steroid is versus what is the risk it is conferring. So we take that decision. But yes, there are quite a good number of patients who do need steroids for much longer. So as I said that, our impression of incidence is just about 1 to 2%. In the most seriously ill ICU patients, it is 1.6%. And those who are not that ill and just a little bit of steroids and all that is less than 1%. So if one believes in that, there is no case for giving a routine mold active or better still mucor active prophylaxis. This practice comes from the hematologic malignancy population. So you have patients with, induction AML, high risk stem cell transplants, high risk myelodysplastic syndromes with induction and so on. So in these patients, the incidence of mold infections is about 8 to 10%. And when that figure is there, then it makes sense to give prophylaxis for that particular thing. So we are not really near that figure. And therefore, I do not think that routine prophylaxis is to be offered. But we have to keep our eyes and ears open. See, there is some interesting fact that, you have, when you use prophylaxis, you must also know what is the residual attributable morbidity and mortality. Okay, so if I don't offer prophylaxis, but I keep my eyes and ears open, pick the disease very early and treat it with minimal amount of surgery and comparatively less treatment intensity, then the residual attributable morbidity and mortality is less. Okay, in that case, I will not think of giving routine prophylaxis to a large number of patients with the hope of preventing disease in a small number. Also remember that these are antimicrobial agents. Today and tomorrow you are going to put in that much of antifungals in the environment. We know what happens when we just pollute our environment with all these drugs. So it is not a good practice to have a blanket and prophylaxis. And now the question doesn't even arise. We don't have drugs enough to treat patients. So where is the question of prophylaxis?
Thank you. Well, what about when you're suspecting and evaluating a patient for
Right, I saw that question and I have already answered it, that whether it is fair to start treatment. Two things. One is that if you strongly suspect, it's not wrong. You could maybe initiate 1 or 2 doses. That won't really harm too much. But let me tell you that it is perfectly possible to make a diagnosis within 1 to 2 hours. You have a strong suspicion, and as I said, we involve Prasoon Mishra as soon as possible. He does all the looking inside, getting this. We have a microbiologist on weight who is going to look at the calcofluor stain. Just need to dissolve tissue and look at it on a calcofluor stain, and you can get the diagnosis in a matter of just 1 to 2 hours. So I don't think it's such a dire emergency that, like septic shock, where the first antibiotic dose needs to be given, say maybe in half an hour or 1 hour. So you can certainly wait. But really, if all this is not possible and you have to wait overnight for all these guys to be ready in the morning, maybe it's not wrong to give one shot. Most of these drugs are very long acting, and therefore even just one dose is sufficient.
Thank you. I have a question. Dr. Milap, do you want to say a question? Dr. Ashwini Milap?
So I've unmuted myself, and so I work in a COVID and non-COVID facility in Palampur in Himachal Pradesh, and being over 61, I'm just overseeing. I'm not actually entering the wards, and I also do a lot of work online now through various companies. So I'm an overseer of the system in certain companies. So I'm seeing a lot of oral steroids in people who don't require oxygen but are otherwise feeling ill. Maybe it's panic, maybe it's physical, but they have high fever also, some of them, and some have COVID marker elevation. So my question to the house is, because this is a ground level question, and this is a very practical issue. A lot of high dose steroids, from the dose of 16 mg twice a day of methylprednisolone onwards or below, or parallel steroids, is being given. Can anybody offer any perspective on giving steroids in fever per se in non-COVID as well as COVID situations? Your take on this?
Thank you, Dr. Milap. Would the speakers like to take this?
Yes, certainly. You want me to answer most of them, or somebody else? Otherwise, you might think that I am sort of bulldozing everyone away.
So you are the best person to answer all these questions. We are all listening.
Okay, I don't know whether that is true, but yeah, let's take COVID first. So, if I think the guideline makes eminent sense that if somebody is not requiring oxygen, we should not be giving steroids. And that is because steroids definitely will increase the replication. See, this is generally in an early stage when we believe that the viral replication is going on. And viral replication would definitely be increased in the early stage. Additionally, steroids will increase hyperglycemia and produce immunocompromise. So if the person is not requiring oxygen, it is at least most guidelines would say not to give. It's not even just it's a recommendation against the use. Okay, so that is one point which we need to keep in mind. Now, would you give it for symptom relief of pain, arthralgia, fever, myalgia, and such things? So probably again no, because many of these patients can be treated with NSAIDs and along with paracetamol and so on. So very rarely would you find a need for using steroids just on this basis. And you have to balance that with the risk of encouraging viral replication, along with all the other things that I mentioned. And therefore, I don't think we should be using them. What about steroids in other infectious diseases? So, there is a small study on typhoid toxicity or typhoid toxemia, let me put it that way, where, in Indonesia, there was this study where they did. And sometimes we have seen patients, and we have also treated just with one dose or so. In a patient where it is a proven typhoid who's drug susceptible, we are giving drugs which are actually effective. Blood culture has been rendered sterile, and yet sometimes the patient continues to have a high inflammatory state. Rarely, but I can't really recommend that on any platform that way. If you just meet me in the corridor, maybe I'll suggest that. But So these are the things which we should keep in mind. So there are other drugs to be used in most of these situations. Steroids certainly should not be preferred,
Thank you.
definitely.
Thank you. Thank you. Baldev, do you have a comment? And then Aditya, please. Baldev.
So I agree with what Dr. Soman said, that unless a patient is hypoxic, these are not to be used. That's the recommendation. However, I will say that ICMR in their guidelines have said that after 6 days of continuous fever and elevated markers, something like that, they should start. That's the ICMR, but I'm not sure on what basis they've said that. But the NIH and CDC are pretty clear on that, that unless somebody is hypoxic, steroids are not to be started.
Thank you. Thank you. Aditya, Dr. Kasarabada?
Thank you. I think one of the other parts to remember is, like, if you look at the recovery trial, actually, where of harm in there, with the odds ratio being with significant for actually harm. So it's not just the fact that it's not going to be effective, it might actually be harming your patients at that point. So if they really don't have any respiratory illness, steroids in these cases, I know the question also says with inflammatory markers and everything else. The reality of it is, while we are checking for inflammatory markers, no study has actually panned out to say that the inflammatory markers have actually worked in any way, like that to any significance level, meaning like if it has gone, the D-dimer has gone from whatever 2 to 5 or 10, it hasn't shown any significance. So treating that number per se has not necessarily been shown to be helpful. So that, I mean, I would highly discourage that practice.
Yeah, very nice comments, exceedingly good comment.
Comments about what is a cutoff for hypoxemia to start steroids?
So I think Dr. Baldev.
Yeah, so I mean, the studies were done with a saturation of 94% and or below. And, obviously, the measurement of oxygen saturation in dark skinned people is not really accurate. It is a little lower. So I would recommend at less than 92 start oxygen.
Okay, thank you. That's a very practical question. I'd really like to hear from others as well. Anybody else with comments, please?
So, like as Dr. Singh said, like the WHO recommended 94 and lower as a part of it. In addition, that's what I think the recovery trial was going after. Practically speaking, when we were being inundated by patients and we were running short of resources, we changed it to go towards more along the ARDS cutoffs of 92 and 88% with similar results. Now, couple of the steroid studies actually went for lower SATs also. Some of the steroid studies which were stopped around recovery trials were aiming for SATs about 88%, if memory serves correctly, which are published in JAMA, but they were going after that. But currently the recommendations for, if you're looking at an outpatient or in the general population, it's about 94% and lower.
Thank you. Any other questions or comments? Or any messages? Dr. Soman, obviously, as a doyen of infectious disease in the area, and also we know about your work at Hinduja as well. Would you please reiterate some messages for our colleagues who are in the front line?
Yeah. Thank you. And I think what has been coming over and over again is that we need to restrict our use of steroids and other immunosuppressive agents, although there is a good biological plausibility that this is what is encouraging the epidemic of mucor, if you will, but although we don't have a direct cause-effect relationship, but that certainly seems to be the plausible explanation. So I think at this moment we should definitely try to restrict as much as possible. There are situations where we cannot, and in those situations, I think close monitoring, patient and physician education. Like maybe if the patient is being discharged home, maybe we can call up his family physician, because after all, they have a large part to play in the delivery and the selection of healthcare also. And therefore, we should try to call them up perhaps and tell them that if this patient manifests any of these things, please pay enough attention to that, or some nice sweet way of saying it.
Thank you.
I have to think about
Thank
it,
you.
but
Doc-
yeah,
Dr.
so these
Salona-
would be important things. And then, of course, additional when the patient presents, so everything that the ENT, radiology, and all of us said. So that's my message. That's all.
Thank you.
Thank you.
Dr. Salona wants to know. Dr. Salona, are you able to unmute? Dr. Salona has a question from peripheral areas. Dr. Salona? I'll read out the question. In peripheral areas with no facility for blood culture affirmation, how should we deal with Vidal positives in home isolation?
Yeah. You may believe me or not, but I have not done a Vidal test for the last 30 years. Okay, so we do rely on blood cultures, of course, as you said, but if you cannot, then there are certain other pointers to typhoid. And one of them is an absolute eosinopenia, along with certain other clinical features. But it's very difficult. And in this setting, I mean, obviously, we should tell them that please avoid drinking unclean water and this, that. So why would somebody get typhoid immediately in the post-COVID thing? I don't know. Means unless this is a general question, then it's a different matter.
Thank
so,
you.
Vidal, I don't think we can rely really on.
Okay. It looks like there are a lot of people doing Vidal tests. Anthony Kolanur, Dr. Kolanur? Dr. Anthony Kolanur? I see that you raised your hand.
Yes, I have got two questions. One is there any justification or rationale in adding methylene blue in the humidifier for oxygen to prevent mucormycosis? Is it a WhatsApp postings are going on? Second question is, is there anything? And is the black fungi and mucormycosis is the same, synonymous or not?
Yeah, I have written a written reply. You might like to see that. I have named which are black fungi. If you want, I'll just tell them they are Cladophyllopora, Mesophylla, and all that. It's not mucor. What mucor will turn the patient's part black. That's a different thing, but the fungus itself is not black. Okay, so that is one question. Now, the next thing is about the oxygen, water, and methylene blue. Methylene blue or, sorry, gentian violet?
No, methylene blue.
Methylene blue. So most people are inclined to put gentian violet in that, but I mean about both of them. Gentian violet used to be a traditional antifungal for the dermatophytes. You know, people used to apply on their skin for some dermatophyte infections. So obviously, it has nothing to do with mucormycosis or the spores of mucor. And also remember that mucor spores are not coming from water. They are coming from inhalation from soil sources and air sources. So the spores are there in the air, not really in the water. So it's not a water pathogen. Like you have Burkholderia, Cepacia, and Stenotrophomonas, Ralstonia. These are all, some of these are waterborne, and through the nebulized oxygen or other nebulizing fluids, they will produce pneumonia in selected ICU patients, but this is not one of them. And about methylene blue, I absolutely know. I had never heard of it also. Anything that looks blue, so maybe we can think about copper sulfate or what else. I don't think it should be.
All right.
Thank you.
Thank you. Thank you. So I think one other important question is, what if you had a CT finding or CT score of 10 and no hypoxemia? Would you start steroids? This is from Dr. Khattar, Aarti Khattar. Would you use a CT score as opposed to a clinical criteria for starting steroids? Anybody? Dr. Baldev, Dr. Kasrabada?
CT score. The patient not. I don't think I would use a CT score for steroids unless the patient. I'm not sure why we're getting the higher CTs done in the first place.
Patient is not, yeah, sure.
Okay. And secondly, no matter what the situation, if the patient is not hypoxic, I would not be starting the patient on steroids.
All right.
I think that goes back to the other part of the question that was there at the last presentation about appropriate use of CTs, which Dr. Joshi had made a very valid point about it. People are getting CTs and comparing their CT scores as a matter of fashion more than anything else. If there is no, if we use those algorithms that we talked about last time, this would not have been an appropriate CT in the first place. Let's just say that this was a high-risk patient and got a CT score. That does not define their illness. It says that they're likely to progress. It does not change anything about there is a chance to progress. Use of steroids without hypoxemia will still be, put them at higher risk for complications as was stated in the last recovery trial.
Thank you. Thank you. So in the interest of time, I know people have to go to work or go to bed. Is there any final question? Does budesonide need to be tapered?
No.
Okay. Do any cutoff for high inflammatory markers, D-dimer to start steroids? I think we already addressed that, but do you want to address that, please?
No, I mean, independent of the inflammatory markers, I do not believe that steroids have any role at all, unless, I think we need to hammer it home that no oxygen, no steroids.
Okay. So Dr. Soman, it looks like there's a Dr. Golwilkar in Gujarat who's using methylene blue for treatment. I think I've seen the YouTube videos as well, but it's obviously not anything that.
No, I have no idea about it at all.
Okay. All righty. Thank you. Any final questions before we sign off? I just want to point out that we'll meet again in a week, and we'll still have part 1 of current issues in the management of COVID. We'll start off with things that are relevant to ambulatory patients and then ICU and on. But I also definitely want to take the opportunity for some fantastic presentations today. We're really thrilled to have senior experts like Dr. Soman and wonderful with Dr. Baldev and Dr. Mishra and Dr. Joshi. Any final thoughts before we call it a day, call it a night? I see that there are 2 new messages. Or dexamethasone, should they be tapered or not?
No. It's
Okay.
only for 10 days.
Okay. Okay, very good. So we have a feedback link that I'm just pointing out here, and we will sign off here. Thank you all. Have a good
Thank
day,
you.
and our best wishes to you as you take care of your patients. Very best. Thank you.
Thank you.
Thank you.